Hello Damsonians. So welcome to this lecture on bronchiectasis. In the previous lecture we have discussed about the topic of asthma and its also relation to COVID. Now it is time to go on to the second of the airway disease, that is bronchiectasis. So in bronchiectasis we'll start with the definition. It is defined as the abnormal permanent dilatation. We'll define it as the abnormal permanent dilatation of the airway. Permanent dilatation of the airways. That is called as bronchiectasis. Permanent dilatation of the airway. So it is typically the structural disease most commonly affecting the medium-sized airways is bronchiectasis. So if we look at the epidemiology of the disease, what is the epidemiology of bronchiectasis? Epidemiology typically occurs in middle-aged people with a female preponderance. Is there. So one of the diseases which can be more common in the female is bronchiectasis. If you look at it carefully, many respiratory diseases are common in males because of two important reasons. One is smoking and second is environmental exposure. So there are very few diseases in respiratory system which are female dominant. One of them is the bronchiectasis. We want to see why. Because if you look at the etiology, of the disease, the most common cause is post-infective sequelae. Most common is the infective sequelae. Post-infective sequelae is the most common cause of bronchiectasis. Rarely, it can also be genetic conditions. It can be genetic causes, which we know two important one, Cartagener's syndrome and the topic of cystic fibrosis, which we will discuss after the end of the first part. So bronchiectasis is most commonly post-infective sequelae. So what is the mechanism? What is the pathology that occurs in bronchiectasis? What is the pathology that occurs? In bronchiectasis, it starts with infection. So which infections can precede bronchiectasis? Most common now in the world has become tuberculosis. It can precede viral pneumonias. It can be preceded by viral pneumonias where adenovirus is there, respiratory syncytial virus is there. So tuberculosis, viral pneumonia as well as bacterial necrotizing pneumonias. Bacterial necrotizing pneumonia are due to Staphylococcus, Pseudomonas and the Klebsiella. So typically you have to remember this group of organisms. They'll keep coming repeatedly in our questions. So post-infective, the disease starts with one of these infections, and tuberculosis is most common in adolescent female. So adolescent female develops tuberculosis. 15 years later they develop the sequelae, that is the sequelae of bronchiectasis. So it is a much more later, many years it takes after the initial infection. What happens because of the infection? Let us look at this. So all these infections in one bracket, because all of them can predispose to development of bronchiectasis. So the most common infection preceding bronchiectasis remains tuberculosis. Remains the tuberculosis. So what happens next after the infection? This infection is going to it is going to cause damage to the airway epithelium. It is going to cause the damage to the airway epithelium. Damage the airway epithelium. It is going to cause damage. It is also going to damage the mucociliary transport. It is also going to damage the mucociliary transport. Mucociliary transport is also damaged because of the infection. Now this damage to the airway epithelium, causes dilated segment of the airway to be formed. Causes the dilated segment of the airway to be formed. So damage to the airway epithelium will occur. Damage to the mucociliary transport. There is damage to the mucociliary transport, which causes the accumulation of the secretions. There is secretions accumulate in the dilated segment. The mucus secretions accumulate in the dilated segment. Now these secretions are very good nidus for bacterial infection. These infections are good nidus for bacterial infection. Good nidus for the infection. They are like a culture media. They are a good nidus for the infection. And this predisposes the patient to develop recurrent LRTI. Predisposes the patient to develop recurrent lower respiratory tract symptom. Needless to say, this recurrent lower respiratory tract symptom infection, when it is caused because of one of them, it perpetuates the cycle. It continues the cycle, leading to progressive dilatation of the affected segment. Leading to progressive dilatation of the affected segment. That is why this is called as a vicious cycle hypothesis. In bronchiectasis, the pathology is called as a vicious cycle hypothesis. Vicious cycle hypothesis. Because the infection is the starting point, and that begets more infection. So infection gets more infection. That is why it is called as a vicious cycle hypothesis. So understanding pathology very important, because the disease, understanding the treatment also depends on that. So once we know the pathology, proceed to the clinical feature. What are the clinical features of bronchiectasis? What are the clinical features of bronchiectasis? The clinical feature bronchiectasis is going to present most commonly as recurrent lower respiratory tract infection. The patient of bronchiectasis most commonly presents with recurrent lower respiratory tract infection with copious quantity of mucopurulent sputum. Mucopurulent sputum. Copious quantities of mucopurulent sputum they are going to present with. Copious quantities of mucopurulent sputum they are going to come with. Recurrent lower respiratory tract infection. Number 2, very important, on the examination of the patient, what you get? You get early and severe grades of clubbing. You get early and severe grades of clubbing. you get the severe grades of clubbing you are going to see. And on the auscultation, we are going to get, you are going to get a mid inspiratory, you are going to get a mid inspiratory, you are going to get a inspiratory crepitation, you are going to get a mid inspiratory crepitation. Mid inspiratory crepitation, which has got characteristic mid inspiratory crepitation with post-tussive changes. What we call it? With post-tussive changes. There is going to be a mid inspiratory crepitations which is associated with the post-tussive changes. So why? When the air passes through the accumulated secretions in the medium sized bronchiole, so when it will occur? During middle of inspiration. When it passes through the secretion, it produces a harsh crepitation, with post-tussive changes. Post-tussive means, tussive means coughing. So post-tussive changes is characteristic of bronchiectasis, because what happens after coughing out of the secretion? Tussive means coughing out the secretions. After coughing out the secretions, the crepitations reduce. The crepitations reduce in intensity. They reduce in the intensity after coughing. So when you have a patient, typically a middle-aged female, presenting with recurrent LRTI, in our country with a past history of TB when she was in a college, adolescent girl, on examination, general examination shows there is a severe grades of clubbing, and auscultation reveals mid inspiratory crepitations are heard which improve on coughing out the secretion, So how do you confirm the diagnosis? So diagnosis of the disease is based on radiological test. HRCT is the gold standard, which shows the signet ring appearance. Tram track appearance on the HRCT. Confirms the disease. Please remember, bronchiectasis is a structural disease. Structural disease can be diagnosed by which investigation? Radiology. Functional diseases like asthma can be diagnosed by functional tests, spirometry. But structural disease can be diagnosed by structural disease by radiology, is confirmatory of the disease. Once diagnosis is made, how do you proceed to the treatment? The treatment is unfortunately only palliative. I don't have a specific cure because damage to the airway is permanent. So what I'm going to tell? Number one, most successful is the postural drainage of secretions. So the best success rate is in the postural drainage of secretions. Postural drainage. So what happens here? Postural drainage. So suppose the patient has a right-sided bronchiectasis, right? So if they turn in the left lateral position and you do chest physiotherapy to aid the postural drainage of secretion. So every day the patient must undergo postural drainage to prevent the risk of infection. Number 2, mucolytics. You can prescribe mucolytics. The famous one, N-acetylcysteine. Thanks to COVID, all these drugs have become famous. N-acetylcysteine is a mucolytic with additional antioxidant property. You can give mucolytics can be given. Prompt treatment of infection, if any. When it occurs, immediately give prompt treatment of the infection. You continue with the annual vaccination, influenza, pneumococcal vaccination to continue. So to prevent the risk of infection, you are taking these steps. So influenza and pneumococcal vaccination can be given. In the Western countries, biological palivizumab has been approved. So palivizumab is a monoclonal antibody against the fusion protein of RSV. Respiratory syncytial virus. Fusion protein of RSV, especially in immunocompromised cases. So viral pneumonias also can predispose to the bronchiectasis. So what we are doing, even after TB infection, small segment is dilated, you continue postural drainage, you give mucolytic support. If the infection comes, treat it promptly. Continue vaccination. Consider palivizumab in immunocompromised cases. Consider palivizumab. But unfortunately, the only potential cure is the lung transplant. Which is not freely available. And the complications of the disease are also many. Let's enumerate. What are the complications of bronchiectasis? We want to see. What complications can they occur with the different mechanism? We know bronchiectasis patients are prone to recurrent lower respiratory tract infection. They are prone to develop recurrent lower respiratory tract infection. This recurrent lower respiratory tract infection can lead to direct complications. What direct complications it can cause? What direct complication can it cause? So direct complication, okay, during the infection, pneumonia, during the infection, the patient can have complications of septicemia. Risk of septicemia, development of lung abscess can occur. There is a risk of ARDS also. ARDS also during the infection. It can occur. Because of the infection, there is also the patient has loss of lung parenchyma due to the repeated infection. The patient has loss of lung parenchyma. Loss of lung parenchyma can lead to chronic hypoxemia, can lead to development of chronic hypoxemia. This hypoxemia we have discussed when we discussed gas exchange defect can lead to cor pulmonale, can lead to cor pulmonale and heart failure in the future, can lead to the cor pulmonale and the heart failure in the future it can cause. Finally, the recurrent infection can also cause increase in the acute phase reactant. Increased levels of acute phase reactants can occur. Increased levels of acute phase reactants can occur, which can lead to secondary amyloidosis, which can lead to secondary amyloidosis can occur. Secondary amyloidosis can occur. This secondary amyloidosis leads to renal failure. Renal failure, which is the most common cause of death. Which is the most common cause of death in a patient with bronchiectasis, hence considered dreaded complication. Hence considered as the dreaded complication. Secondary amyloidosis. So what is the problem? Repeated infection. The infection itself can be fatal because it can cause septicemia, lung abscess and ARDS also. Because of the infection, there is loss of lung volumes, which can lead to defect of gas exchange, leading to cor pulmonale and heart failure. And chronic inflammation can cause secondary amyloidosis, leading to renal failure, which is a dreaded complication of the disease. So what can we put it together? The overall prognosis of bronchiectasis is poor. The overall prognosis of bronchiectasis is poor. The overall prognosis of bronchiectasis is poor. We have to say it is poor because what are the problems? It affects productive age group, not very old, no? Middle age. Productive age group is affected. The disease is permanent dilatation. So I can offer them only palliative treatment. Palliative treatment can only slow the progression. The only potential cure is to go for a lung transplant, which is not commonplace. So if I don't do the lung transplant, patient is prone to multiple complications which can be life-threatening. Hence, the overall prognosis is poor. So what we must remember, bronchiectasis and its complications are best prevented. It's not like 100% we can never prevent. Infections are part of our life, especially in the underdeveloped country like ours. Infections are commonplace. Infections are commonplace, leading to the complication, right? So keep it here. So what are the points we must know about bronchiectasis? Bronchiectasis is an abnormal permanent dilatation. Starts with infection, begets more infection, causes more damage, more infection, more damage, more infection. Vicious cycle hypothesis. So we are breaking at each level. One, what you are doing? You are preventing accumulation, postural drainage. You are preventing mucolytic. so that it will go out. You are giving vaccination, early treatment of infection you are trying to give, right? But if it occurs, you can only do a lung transplant, right? So this is about our post-infective bronchiectasis, post-infective causes of bronchiectasis. But we have got two genetic conditions also. Let's discuss them for MCQ. So genetic discussion, genetic conditions are there. We have got to discuss between Cartagener's syndrome. We have got to differentiate Cartagener's syndrome. We want to differentiate Cartagener's syndrome with the cystic fibrosis. Cartagener's syndrome with the cystic fibrosis. Both are autosomal recessive in inheritance. Both are autosomal recessive in inheritance. That is common point. So why we are discussing them together? Why we are discussing them together must be known to us. So why we are discussing? Because both are inherited causes. Both are inherited causes with autosomal recessive inheritance, and that is why both of them can come with a young age bronchiectasis. Because what we have seen, commonly bronchiectasis affects middle age. Commonly bronchiectasis affects middle age. So before 30, if a person gets bronchiectasis, you must suspect genetic condition. So write a clue here. So onset before 30 years. Before 30 years is rare, but you must consider genetic causes. Onset of bronchiectasis before 30 years is rare, but you must consider genetic causes, which we are discussing together. So both of them share few common features. That's why we are discussing them together, and you have to highlight the differences in the MCQ. So let's start with Cartagener's. What is Cartagener's? It is a defect in the cytoskeleton, dynein arm defect. So Cartagener's syndrome, previously called ciliary immotile cilia syndrome. So there is a ciliary dyskinesia. It is a ciliary dyskinesia syndrome where there is a dynein arm defect. There is a dynein arm defect. The hook-like process, dynein arm defect of the cilia. There is a dynein arm defect of the cilia, impairing the motility of the cilia. So Cartagener's syndrome was also previously called immotile cilia syndrome, but that term is no longer preferred because cilia are not totally immotile. But yes, there is a lot of dyskinesia, defect in the movement of the cilia are present. Defect in the movement of the cilia are present. Considering that they are a inherited disease, they present between 20 to 30 years of age. 20 to 30 years of age. What do they present with? The triad of situs invertus. Bronchiectasis presents with a triad of situs invertus is there. The triad of situs invertus. There is bronchiectasis. Situs invertus. There is bronchiectasis. So look at the points. Cartagener, how will they present? How will they present? Ciliary dyskinesia is there. Dynein arm defect is there. which causes them to present between 20 to 30 years of age with the classical triad of Cartagener's syndrome. The classical triad of sinusitis, there is the sinusitis, there is bronchiectasis and the situs invertus, and the situs invertus can occur. So what we importantly highlight here, this is a cause of young age bronchiectasis. So Cartagener's is a cause of young age bronchiectasis. It is a cause of young age bronchiectasis. Let's compare it to the cystic fibrosis. It is also inherited problem, but what it is? It is due to defect in the CFTR gene. What is that? Cystic fibrosis. Cystic fibrosis transmembrane conductance regulator. Transmembrane conductance regulator gene defect. Cystic fibrosis transmembrane conductance regulator defect is there, because of which there is a defect in the chloride transport. There is a defect in the chloride transport, leading to the hyperviscosity, of the exocrine secretions. So exocrine glands are affected. The gland whose opening is opening to the external, on an external opening. So hyperviscosity of the exocrine gland it causes. Epidemiologically, they can present in infant also, depending on the severity of the disease. They can present as young adult also. They can present as elderly also. So the cystic fibrosis gene mutation, depending on the severity of the mutation. If the mutation is severe, they can present with meconium ileus right at birth. They can present as meconium ileus right at birth, because 90% cases have pancreatic involvement. So pancreas are commonly affected in the disease. Exocrine gland, pancreas are affected in the disease. So if the mutation is severe, they can present right at infancy, leading to meconium ileus. But in the middle age, the most common presentation is bronchiectasis. Most common presentation is the bronchiectasis, lung involvement. So repeated infection will occur because of the hyperviscosity of the mucus secretions. There is recurrent LRTI leading to bronchiectasis. Elderly can just present as pancreatic insufficiency. So abdominal bloating, indigestion, more of a GI symptom can be the presentation. GI symptom can be the presentation. So as I told you, why we are studying them together? Because both of them are autosomal recessive inheritance, because of which both are causes of young age bronchiectasis. Both of them are differential for young age bronchiectasis. Young age bronchiectasis they can be part of. So next question, in which disease does infertility occur more commonly? Another common feature of both the diseases, infertility is common in both. Infertility common in both. So typical mistake by students, when we think of immotile cilia, we think sperm immotility, but fertility common in both genders, common in both gender, because both sperm and the fallopian tube motility is lost. Fallopian tube motility is lost. That is why it can affect both genders. It can affect both genders. It is the cystic fibrosis where 90% of the infertility occurs in males. It is the cystic fibrosis where 90% of infertility occurs in males. Why? Because they have a anatomical defect in the vas deferens. They have a anatomical defect in the vas deferens. Anatomical defect in the vas deferens. 90% of infertility occurs in the males. 90% of infertility occurs in the males. Occurs in the males. That we must know. 90% infertility. Next question. What is the diagnosis and treatment? Diagnosis and treatment. The diagnosis is just based on the clinical syndromic association. The treatment of the disease is only palliative, but it is not a dangerous disease. No, situs inversus, malrotation of the heart, does not affect function. Sinusitis and bronchiectasis continue medical treatment. So overall favorable prognosis. Overall a favorable prognosis can be done. Overall favorable prognosis. Comparatively, you are talking in comparison. So cartaginous is a inherited disease having triad, infertility, but death is not immediate. Prognosis is overall favorable. Compare it with the cystic fibrosis. Let's compare it with cases of cystic fibrosis. Multiple MCQ questions are there. So first question is best screening test. What is the best screening test that you can do for a case of suspected cystic fibrosis? What is the best screening test for cystic fibrosis? Remember, it depends on the age. So best single answer is to write the sweat chloride levels. Best single answer is to write the sweat chloride level. But in infant, sweat glands are not even developed. So what do we do? Blood test, genetic screening, immunoreactive trypsinogen. Immunoreactive trypsinogen is used for genetic screening for cystic fibrosis. So you will see nowadays that when the baby is born, the hospital offers a panel of genetic tests. They offer a panel of genetic tests for common diseases. So in cystic fibrosis, the child sweat gland is not developed yet. So there you can screen them with the IRT. Screen them with the IRT, immunoreactive trypsinogen. But best single answer remains sweat chloride level. If the sweat chloride level is positive, the sweat chloride level, if it is positive, what is the gold standard or the most specific test? You proceed to the next. Gold standard or the most specific test, that is genetic test for the CFTR gene. genetic testing for CFTR gene mutation. But if the sweat chloride level is negative, if the screening test is negative, what is the most sensitive method better than sweat chloride? Sensitive method is to go for transepithelial potential difference. Transepithelial potential difference calculation can be done. That is the most sensitive method. So why are we not doing that only commonly? Transepithelial potential difference, an invasive procedure, expensive procedure. So when I want to do screening, I will use sweat chloride level. If the sweat chloride level is positive, I can go for genetic testing. But if the sweat chloride is negative, I can ask for transepithelial potential difference to look for the disease. Once confirmed, what is the treatment? What is the treatment of cystic fibrosis? What we have got? Gene transfer. We have got gene transfer using adenovirus as the vector. Gene transfer using adenovirus as the vector has been approved, and it is the best treatment because it offers potential cure. It offers potential cure by delivering the defective gene into the body. By delivering the defective gene into the body. Yes. So recently in the news, for motor neuron disease, for spinomuscular atrophy, we have got the Zolexma. That is the world's most expensive injection. 16 crore for spinomuscular atrophy. Why? It delivers adenovirus mediated gene transfer. The deleted or the abnormal gene is taken to the body using adenovirus as a vector. Similarly, in cystic fibrosis also, gene therapy is available, which is offering potential cure in this patient. So overall prognosis again favorable. Prognosis is again favorable. So look at them. What are these two together? These are the young age onset of bronchiectasis. That's why reading them together. Common MCQ question. Both of them, cartagenars and cystic fibrosis, are autosomal recessive, presenting as young age bronchiectasis. So most commonly bronchiectasis occurs in middle age, 30 to 50. But if you get a young age, you think of inherited disorders. Because if after 50, we are basically looking at post-infective causes. And most common remains tuberculosis. In our country, adolescents get TB and they develop progress to bronchiectasis in their middle age. But once bronchiectasis develops, prognosis remains poor because complications are many and there is no permanent cure. Right? So this is our topic of medium airway dominant disease. Asthma is large airway dominant. Bronchiectasis medium airway dominant. In our next video, we will discuss about small airway dominant, that is COPD. Right? Keep watching.